Good evening. Can you hear me?
Good evening, sir. Yes, we can hear you.
Can you see the screen?
Yes, sir.
Okay, right. So let's talk about some psychiatric emergencies. This is a lecture we do for pre-interns. Right? Just before internship, we all will have two sets of programs, one from the Ministry of Health and another from the GMO. Various things will be like a refresher course on how to be a good intern in your medical, surgical, GNOBs, pediatric wards. So even though you all won't do an internship in psychiatry, there are these psychiatric emergencies occurring. So you need to be aware, right? So what we'll do is we'll just discuss some actual patients who came to Ragama in the medical and surgical wards, an aggressive patient, someone with ataxia, a patient with muscle twitching, a patient with vomiting and eyes rolling upwards, someone with fever. Okay. What I want you all to do is I want you all to answer, you all can do, because you all don't generally answer vocally, to type your answers in on the chat. Okay. And I want you all to send them quickly. It's already late. You can quickly stop them. Okay. So this is your first case. Read this carefully. Jot down the important things you think are important before the questions come. A 45-year-old labor is brought by co-workers and admitted to the surgical ward after being assaulted at work. The nurses inform you that the new patient who was admitted is talking to himself and laughing. When you ask him what happened, the patient says that all people are jealous of him, but God will punish them as he is the Son of God. No collateral history is available when you come to clerk the patient. His vital signs are normal, other than a tachycardia and pupils are normal. No head injury seems to have occurred. You are in the process of writing basic investigations, then you suddenly see him assault an attendant. Right? So this is the scenario. Here are some options of what you do in this emergency. All right. What I want you all to do is type in the chat the sequence by which you all will do this. So if you think your first thing you do is call your senior, all these options are right. Your first thing will be E. Then if you think you're going to attempt verbal de-escalation, EI. If you're giving oral halogen, EIJ, like that. Okay. So send in your answers quickly. This is the scenario. Okay. 2 minutes, quickly send. Right. So most of you are somewhere there. In emergencies, it's very difficult. You have to do everything together. But like in single best response MCQs, you need to pick what you will do first. Right. So the first thing you do is you call other staff and go in with numbers. This is a violent man. Right. So sometimes when you are intern, when you become a doctor, people respect you, which is nice. Like, Lokuma, Pudi Matyari, Pudi Nona, Hari, Doctor Nona, people get up when you go. When you're a medical student, nobody really respects you that much. So, but everything changes when you're an intern. But that doesn't mean everybody will listen to you, especially not a manic patient. Right? So you know the patient is manic. You will not go, you will also be assaulted. Right? So if one of my patients gets aggressive in the male ward, I will go in with myself, my registrar, my attendants, male nurses. If any male medical students are there, I will call them. And if there are other bystanders, I will also use them. I'm not going to fight with a manic patient or get assaulted. Try not to, at least. So you go with numbers. That usually settles the situation. The patient also realizes. Then you attempt to verbally de-escalate. Don't go straight away and jab or anything, right? While you're doing that, you tell another nurse to call the SHO and registrar as well as the security, so that you have more numbers, and the uniforms and all help in these situations. That is important. Right? So now you're arranging the security of the ward. Then I've also already informed, you don't have to wait for the registrar or consultant to come. You can offer oral haloperidol. If not taking, you can give IM haloperidol. All right. Make a psychiatric referral urgently, but what is important is, this is a psychiatric patient, will make a psychiatric referral කියලා හිටියොත් මේ ලෙඩ තව 10 දිනකට විතර ගහනවා. Right? Psychiatric referral එක යන්න ඕනේ, attendant ගෙනියන්න ඕනේ, psychiatrist එන්න ඕනේ, right? ඔය ටික වෙනකොට වෙලා යනවා. You make it and you can tell them it's urgent, but by that time you can't wait for the psychiatrist to prescribe IM haloperidol. You have to give it. Director and police post needs to be informed, as it's a legal matter now, assault. But those come late. Those are not urgent things. Tying the patient to the bed is the last resort. Only if there is absolutely no way of controlling him for the patient's own safety or the people around him. But that's a temporary measure. Never say that in an answer unless asked. Right? You go to the urgent admission in the female ward afterwards. So this is the way you do it. Right? You should know rapid tranquilization very well. It will be asked sometime in your exam. Right? These are the lessons to learn. You have to look after yourself. Right? There's no point trying to save people and getting assaulted. Right? It's like, wearing masks or something during COVID. No point getting COVID. I mean, you can't control it, but you should try to minimize it. So something like that. First, make sure you're safe. Always get help. Inform seniors and treat. And you can learn from the experience. What could you have done better? Not you. What could this intern have done better? You can keep the people who brought him. In the scenario you might remember, he was brought by 2 friends whom he worked with. 2 other, maybe like bosses or manual rebels, who are also strong men who have some control over this man. Right? If they won't let him hit anybody, they will hold him down. Right? So what happens is nurses and all always chase people away. Right? But from a doctor's point of view, mental health point of view, it's always better to have somebody. Right? So you have, as an intern, can say, okay, you can say, you need to know the story. The patient is not going to give a good history. He is for head injury observation and everything. Right? That will save you, give you a better history. That will also prevent this damage occurring. Right? Moment this patient says psychotic things and about God and all, you can make the referral and call your seniors early before trying to do a full clerking even. You don't need to take a full detailed history and mental state examination when you're the surgical lecturer. Right? කතා කරන්න ගියපු ගමන් මේ මට මොකුත් ප්‍රශ්නයක් නැහැ මගේ මම දෙවියන් වහන්සේද මොකක්ද ඒ වගේ එකක් කියපු ගමන් හරි හොඳයි කියලා you don't have to try to say him නෑ වා දෙවියන් වහන්සේ නෙමෙයි ඒ ආගියුමන්ට් එකට යන්න ඕනෙත් නෑ full detail psychiatric history අපි expect කරන ඒ වගේ history එකක් ගන්න ඕනෙත් නෑ psychotic කියලා දන්නවා පට ගාලා එළියට ආවා SH ට call එකක් දෙනවා psychiatric referral එකක් දානවා ඊට පස්සේ try කරනවා මොකද්ද කරන්න කියලා එතකොට ඔය ගහන්න කලින් you have informed seniors and they might have told you මේ වෙනකොට බෙහෙත් දෙන්න පුළුවන් කියලා right the moment you identify he is properly psychotic you can treat you can inform document and treat as a HO you are allowed to treat and if it's rational it's perfectly all right nobody will find fault with you for giving haloperidol or olanzapine to this patient so early prevention is the main thing the other thing is informing the staff that this patient can become violent ඇතෙන්දලා එහෙම ගානක් නැහැ ඔහේ ඇවිදවි සින්දු කිය ඉන්නවා බෝඩ් එකේ ඒගොල්ලන්ට එච්චරම තේරුමක් නැහැ ලෙඩොන්ට කෑ ගහනවා they don't realize කෑ ගහන්න පුළුවන් ලෙඩා කවුද බැරි ලෙඩා කවුද කියලා so you have to tell the staff මෙයා ගහගෙන ඇවිල්ලා තියෙන්නේ මේ හොඳටම psychotic හිතන් ඉන්නේ මේ දෙවියන් වහන්සේ කියලා god එයාගේ තාත්තා කියලා මෙයා ඕනේ වෙලාවක පැනලා යන්නත් පුළුවන් ගහගන්නත් පුළුවන් කියලා inform කරලා document කරලා තිබ්බොත් it will prevent the situation and you're also covered right so in essay questions you will be asked questions like this not directly asked about things so always think and write answers similar to this which would prevent the situation what preventive measures could you have taken to prevent this is an essay question and then you will think what could have been done right so that's important a bit about rapid tranquilization all of you all need to know this oral haloperidol 3 to 6 I have told you all about rapid tranquilization before in schizophrenia it doesn't mean IM medication as some students think it means giving it rapidly oral or IM oral haloperidol and clonazepam are the ones we give in the ward can repeat in an hour give IM haloperidol 5 milligrams midazolam 5 promethazine 25 OI doses then angindone can go up to about 30 milligrams of haloperidol this is your second patient read the scenario well a 36-year-old farmer is brought to the ward after falling down while working in the fields his father says he had worked harder than anyone the last few days and hadn't stopped work even for lunch but they noticed him to be swaying while walking he mentioned that the son had an illness snayu amarva for which he takes treatment and regular blood tests are done on examination you notice prominent tremors of the hands the patient is disoriented in time and place he is afebrile vital signs are normal and the rest of the CNS examination are unremarkable read the scenario your questions will be there next send in your answers okay look at the questions well I'll show the scenario once more this is the scenario again these are your questions send in your answers Good. I mean, most of what you say is right, but uh, very few people will, write A, B, C, D and write the four. When you're asked to write four, final year medical students, you need to write comprehensive clear answers. So you just need to put A, B, C, D and write all together rather than write A1, B1. It's very difficult to read them. And be clear with what you're saying. Okay, so these are the answers. And see if you have got 100, for them because they are easy. So it's more likely lithium toxicity and dehydration. So you have somebody who is working excessively, taking treatment with monitoring. Monitoring is usually done in psychiatry if it's clozapine or lithium. You don't do any other monitoring, so it's like that. The fact that he worked harder than everybody suggests he was manic, so bipolar affective disorder, currently manic. And the swaying is the ataxia, and the tremors is also a feature of lithium toxicity. And the definitive treatment is IV normal saline. So you need to be very clear with this. Quick answers, and we'll talk a bit about lithium toxicity. It's a dose-related side effect of treatment with lithium. It's more likely if renal impairment is there, and renal impairment is best measured not by creatinine or the blood urea or the electrolyte levels. It's better to look at the EGFR, which you get when you do a creatinine. The EGFR stage comes in a lot of reports. Stage 1, stage 2, that is the important one. Seen more in the elderly because of the renal impairment. If you take an overdose, or like in this scenario, working hard in the hot sun, and it's mentioned that he was working so hard, he didn't even eat and drink. Right? So it's the dehydration, and that is something we advise the patients also. Sri Lanka is a hot country. Drink adequately when you're taking lithium. The symptoms are ataxia, poor coordination, muscle twitching, slurred speech and confusion. It can progress to coma and fits and death. Right? Permanent neurological and renal damage going into CRF is reported if you don't treat it. Right? So you need to know about lithium toxicity. How do you treat it? Stop lithium immediately. You need to mention this if it's an essay or even this thing. I won't give any more lithium. Quickly do a lithium level. Toxicity is around over 1.5 millimoles per liter. Hydrate well. At home itself, you tell them to start drinking water, even in the ward. Saline cannula දැම්මත් කමක් නැහැ. වතුර බොන්න, juice එකක් වගේ salt තියෙන දෙයක් බොන්න පුළුවන් නම් it helps with the excretion. Start a normal saline drip, send it quickly, monitor the input and output, and do daily lithium levels to see if the lithium is getting washed out. If it is coming down, even if it's high, it's okay. But for some reason, if it's not coming down, you're worried. And dialysis is an option. It will be like an MCQ, treatment methods for lithium. Lithium toxicity, we rarely do it unless there's some serious problem. And the lithium, you take an overdose and it goes over 4 or something. Once I had a patient who took an overdose, but we got the nephrologist involved. They said, hydrate and we'll arrange dialysis if it's not going down. Next day it had come to 2.8. The next day it was 1, like that. We didn't have to give dialysis. So it's usually not needed, but remember that. Okay, there are always options. It's treatable. Okay. This is your next patient. 25-year-old garment factory worker is brought late at night by her friends in a hostel to the hospital. She has been receiving treatment for 6 months from a clinic since she had problems with sleep after she broke up with her boyfriend. The friends have not noticed her fallen on the floor unconscious and an empty bottle of pills near her. She has written a note to her parents saying goodbye and sorry, and she loves them a lot. She is confused and does not give a proper history. She is febrile. You notice muscle twitching on general examination. Her pulse and blood pressure fluctuate while being monitored. Read this carefully. These are your questions. You saw the questions. I'll show the scenario once more. Okay, send your answers. Okay, good. Yeah, some of your answers are good. Most are right. I'll give the answers, and then someone is asking a question. I'll come to you. All right. So the answers are serotonin syndrome. You have amitriptyline, imipramine, which are TCAs, fluoxetine, sertraline, which are SSRIs, venlafaxine, which is a SNRI. Any antidepressant is okay for this answer, right? So we work on a serotonergic theory. Serotonin is a monoamine. We believe that less serotonin levels, a very simplistic way of thinking at it. Depression is far more complex, but the chemical theory is less serotonin. So anything that increases serotonin can cause a surge of serotonin, which can cause serotonin syndrome. So the tricyclics, SSRIs, SNRIs, the NASA, which is mirtazapine, any of it can cause serotonin syndrome. Your diagnosis is severe depressive episode. It's not a normal adjustment, not the normal breakup. Right? Poor sleep, 6 months, not adjustment, a suicide note, saying sorry, guilt, right? Found unconscious. The dose of this overdose is just not a little bit of tablets. She was found unconscious, caused such an increase in serotonin. So it's a serious suicide attempt. Right? What do you tell the friends? right? Friends will come, they will have their own life, they will have their classes, but they would have done the right thing by bringing, but till her family comes, you will ask them to stay with, right? These are the practical things which will save lives. Sometimes that's why, practical, fast thinking doctors are sometimes better than, first class or 10 distinctions it shows, because that one will know theory and just see the patient and write the right medication and go. But if somebody chats and tells the friends, maybe like that could be the key. If they are in ward 21 or 22 or something, they can jump, right? It has happened. There have been patients admitted to our wards, and then the next thing you know, they are talking about a patient brought from the train station who has jumped in front of a train, and you go to see the body, and it is the patient who was in the ward. Nobody has noticed till then that they have gone missing. You know how busy a medical casualty is. You can't expect the staff to keep an eye on everybody. There'll be one person with a myocardial infarction, another person with stroke, Guillain-Barré, chronic acute asthma, the suicidal girl or boy can just walk away, right? So very important, keep the bystanders, get the family down as soon as possible, okay? Right, so serotonin syndrome is something you all need to know about. It's a neurotoxicity syndrome. When medication used to potentiate serotonin or 5-HT action are prescribed, all antidepressants increase serotonin levels. So all antidepressants can cause serotonin syndrome. It's seen when there's a high dose of antidepressants. So when the depression is severe, we sometimes increase the dose. When we treat anxiety disorders and OCD, we increase the dose. You give higher doses of SSRIs in these conditions. Suddenly, if you increase the dose, let's say 20 fluoxetine made 60 without going to 40 first, right? Sometimes we do things like that, which are not good. If you take an overdose, like in this girl, and if you combine antidepressants, right? When depression is resistant, we tend to combine them. You give 2 antidepressants, not ideal. At your level, you shouldn't do it. At a basic, y'all are practicing at a basic MO level, not specialist. You give one antidepressant and you switch, right? If it's not working, you switch, you increase the dose. If that's not working, you switch. You don't combine antidepressant at your level. That is done by specialists in the field. The symptoms of serotonin syndrome are myoclonic jerks, that is the twitching, right? Nystagmus, headache, tremor, rigidity, those are the neurological features. Psychologically, the patient is irritable, they are confused, agitated. We can go into a hypomania, right? They'll be very agitated because the sertraline increases the mood. Go into a coma, which is more neurological. Then you get fever, sweating, diarrhea, the postural instabilities, cardiac arrhythmias, which are autonomic dysfunction, right? So you know the features of serotonin syndrome. How do you manage it? First, you avoid combinations, right? MAO inhibitors, I don't talk too much. I don't know whether anybody has taught you all. We don't get them here. We don't use them here. But for MCQs, it can come. We don't use them. But MAO inhibitors have a lot of interactions, right? Monoamine oxidase inhibitors. Venlafaxine and clomipramine, we try to avoid. High degree of suspicion if somebody on SSRIs or on antidepressants has these features: altered consciousness, right? Fever, postural instability. Stop the medication immediately. And it won't immediately settle. Realize that SSRIs have long half-lives, right? So they may take. So sometimes you give MCQs like that. Stopping the antidepressant causes immediate relief or something like that, right? No, you stop it and you have to monitor and support the patient for a long time because they will be there in the blood for a long time. Supportive treatment is the main thing, but there are specific treatments. Antiserotonergic agents called cipraheptidine is there, and propranolol is more for the calming effect or the postural, or the autonomic instability, the tachycardias and things like that. But cipraheptidine is antiserotonergic and you can use it. So this is your management, but the supportive management, hydrating, washing it out, maintaining a good urine output, measuring the pulse, BP, controlling the fever, those are the important things. Okay. Your fourth patient. A 20-year-old university student is being treated for fever and severe gastroenteritis. He is on oral ciprofloxacin, IV saline, IV metoclopramide, and paracetamol. You are informed that the patient is behaving abnormally. When you examine him, you notice his eyes are rolled up and he is in distress. His neck muscles are extremely tight and he is unable to speak. The patient is thinly built, has a tattoo on his forearm, and on admission notes you notice alcohol and cannabis occasional use mentioned. So read your scenario before the questions come. It's MCQ. What is your most likely diagnosis? And for your benefit, write your management plan also. What will you do immediately? Write the correct answer first, A, B, C, D, or E, and write your management quickly. Just what will you do? Okay, 2 minutes. This is the scenario. Write the letter of your answer and what you will do. Okay, good. So those who have sent the answers are mostly right. It's good if you can send a dose also, right? So acute dystonic reaction, right? What would you do on discharge, which is important? Mention in bold letters that the patient developed an acute dystonic reaction to metoclopramide. So out of the drugs which are mentioned here, metoclopramide, which is a commonly used antiemetic, is known to cause extrapyramidal side effects, especially acute dystonic reactions. So it's not only antipsychotics that cause it, but you learn about it because antipsychotics are more likely to cause it, especially typical antipsychotic drugs. So you don't get caught. This has been given as questions, and there are students who put cannabis-induced psychosis and all. These are not features of cannabis-induced psychosis. Just because somebody drinks or smokes doesn't mean everything is related to that. So those are sort of things to trick you all. If you all know cannabis-induced psychosis well, you know alcohol withdrawal well, you will know that these are not features. That you need to know acute dystonic reaction well as well. Okay, all right. So an acute dystonic reaction occurs soon after treatment started with antipsychotics. But remember, not only antipsychotics. Young males are more likely to develop. So remember that. Typical antipsychotics are haloperidol, chlorpromazine, trifluoperazine, and intramuscular antipsychotic injections like IM haloperidol or IM flufenazine, IM flupentixol are more likely to cause it. Torticollis, the neck, sternocleidomastoid going into spasm, tongue protrusion, grimacing, opisthotonus, and it can be easily mistaken for psychotic behavior. So this is also something you have to be very wary of. When you have a patient with psychiatric illnesses, whatever they do is put onto the psychiatric illness. On a psychotic letter, so be very careful. Those are involuntary and you have to treat quickly. Stop offending agent is the most important step. Some of you all have written that. Well done. So remember that, sometimes we write an answer and come and think you have done well. So if you write acute dystonic reaction, give benztropine, that's a good answer. Right? But if somebody else writes, stop the antipsychotic, right? Stop the medication. An acute dystonic reaction, stop the medication, give IBM benztropine 2 milligrams, put the dose, mention on the diagnosis card that this happened. That is a 100-mark answer, right? The answer you thought was good is 50, right? So always try to elaborate. Elaborate can be comprehensive and iritunak tila tunak gahaneke pahak liyeneke is not elaboration. That is not being sure. About liyana tune වැදගත් දෙයක් ලියන්න and think what else කියලා. You will not be cut marks for writing like that, right? But if you ask for 3 things, the 4th and the 5th won't get marks usually. Right? So treatment is IM benztropine 2 milligrams 10. IM promethazine also works. Sometimes that's why when we rapid tranquilize, when we give IM haloperidol, giving promethazine has 2 effects. One is it calms the patient down. It's a sedative. The other thing is it reduces the chance of extrapyramidal side effects with haloperidol. If they can swallow, if it's not affecting the laryngeal muscles, you can give oral benzhexol, oral benzodiazepines, but usually you have to go IM. Documentation is very, very important. Acute dystonic reaction is a life-threatening condition because the intercostal muscles which are involved in breathing, laryngeal muscles can go into spasm. So it's a life-threatening, urgent thing. Among the extrapyramidal side effects, you need to know acute dystonic reaction, akathisia, Parkinson's, and tardive dyskinesia, and they come chronologically. Acute earliest, akathisia, days to weeks, weeks to months, Parkinson's, months to years, tardive dyskinesia. Okay, so know all these side effects and what to do in an emergency. Okay, your last patient, you must be sleepy. Okay. A 23-year-old patient with polysubstance misuse becomes aggressive on the medical ward. Your consultant asks to administer IM haloperidol 5 milligrams stat and refer to psychiatry. The psychiatry MO starts the patient on oral haloperidol 3 milligram BD and asks to arrange a transfer to the nearest psychiatry unit. Prior to transfer the next day, the nurses mention his temperature is 101 degrees Celsius and he is not moving or speaking. Read your scenario well. And answer these questions. This is your question, the scenario. These are your questions. Okay, start sending them. Last one, then you can go. Okay, so most of your the answers are good. It needs to be concise. Not everybody seems to be. It needs to be. These things need to be 100% clear, right? These are emergencies, no? Right. So the answer should be neuroleptic malignant syndrome. The high fever is mentioned. It's a triad of symptoms: high fever, disoriented or altered consciousness, generalized rigidity. Postural instability is also there. So you can say it's 3 or 4 main features, but the 3 cardinal features are high fever, disorientation, generalized rigidity, may or may not have postural instability. All right. The CPK level, right? Mention if you all know, it will be usually over 1,000. That's a good thing to say. It's not. If there's an MCQ saying the CPK level is diagnostic, that's false. A bit of an unfair MCQ, which is, I think, there in the common MCQ pool also, because CPK can be high in a lot of conditions. Right? However, if somebody has been given antipsychotics, we have these features and the CPK is also high, it is very helpful in confirming the diagnosis, right? But there is no diagnostic test as such. I hope that's clear, right? Because we argued also in an MCQ thinking that, a lot of psychiatrists also said, no, it's diagnostic with correct clinical features, but that's not what diagnostic means. Diagnostic means you don't need clinical features, it's just diagnostic, right? So with the proper clinical picture, it is very likely that it confirms the diagnosis, but there are other reasons why the CPK level goes high. I hope I haven't confused you. You can ask me again if that's not clear. There are specific medications always. You treat with short-acting benzodiazepines. I saw that you all have written lorazepam. That's the correct answer. But lorazepam has to be there, right? We don't have it all the time. Bromocriptine, Ramtrelin are specific treatments, antidopaminergic, and for the muscle relaxation, Dantrolene. You don't need to know the doses, but know the medications. You can always look up the BNF when you're giving them. Haloperidol dose එක rapid tranquilization වගේ I will look at the BNF කියලා කියන්න බෑ. මේ වගේ එකකදී කියන්න පුළුවන් because they are rarely given drugs. So you need to be sure. So it's better to not write without being sure than to check and write. Okay. So a bit about neuroleptic malignant syndrome. It's a rare condition, but life-threatening. Only about 0.2% of patients treated with antipsychotics get it. Usually within the first 10 days of treatment, it comes early. Onset is rapid and peaks around 24 to 72 hours, right? There are motor symptoms. Generalized rigidity is the most common one, but you can also have dysphagia because all muscles are affected, and you can have dyspnea. These are all worrying things. Psychological symptoms, altered consciousness is the most important one, but you can be stuporous, not talking, not moving, and mute. Hyperpyrexia is a cardinal feature, also autonomic symptoms. BPs. I saw some people had recently raised BP, right? So that is also right because it can be raised, but that's not a proper answer because it can be high BP or low BP. It's the fluctuation that matters, right? Tachyarrhythmias are there, increased sweating, salivation. Complications by which the patient will die are aspiration pneumonia, thromboembolism is common, cardiovascular collapse, and renal failure is also there from the large muscle breakdown can lead to renal failure. Mortality if untreated is about 10%, so that's high mortality. After stopping the drug, it will last for about a week or two, gradually reducing. If it's a depot medication, it will take long. If you can get an ICU bed, it's good. So sometimes when you do exams and all, you'll be asked, I will manage the patient in an ICU bed. Again, confidence answers. Some consultants can be a bit annoying. They'll be like, oh no, how are you getting an ICU bed? Ideally, I would like to manage in an ICU bed, but practical vendor you will realize that ICU beds are lazy, right? So I will try. You will definitely get a physician's help, transfer to a medical unit I will treat along with the physician. I'm aware that an ICU bed would be ideal because there's a high mortality, but it might be difficult to get an ICU bed, in which case I will work closely with the physician and try to manage his or her condition. And supportive management is the mainstay, keeping the autonomic, preventing aspiration, managing the fever, maintaining a good urine output so the muscle breakdown doesn't, the myoglobinuria doesn't increase and cause acute tubular necrosis, it's flushed out. Right? So maintaining a good urine output is crucial. Like in lithium toxicity, you're washing out everything that is toxic. The specific treatments are bromocriptine, dantrolene, benzodiazepines help with the condition and help control the psychosis also. And you can give ECT, which is good for the psychosis as well as the NMS. Right? How do you start? You wait 2 weeks and you start a different class. So this patient was given haloperidol. So but he's psychotic, so you need to give something. You give olanzapine or quetiapine, something like that, rather than giving the same thing. And you document it well once again, developed neuroleptic malignant syndrome with IM haloperidol. So the next time the patient is disturbed, he will possibly get only IM midazolam if needed, or try to be managed with oral olanzapine to prevent NMS occurring. Right? So in summary, if you are pass out, and I'm still giving this lecture for the interns, you might get to hear this again. You don't have to join them if you know it. And congratulations on passing. But all intern house officers, which you all will be soon, should be completely confident in managing an aggressive patient. Know that well. Predicting and preventing risk can stop most aggressive acts occurring, right? Keeping the bystanders, moment you see, treating quickly, informing seniors, do those. Look after yourself. No specific details about neuroleptic malignant syndrome, lithium toxicity, serotonin syndrome. Have notes on these, small notes. Right? Don't just study and write them down and know them. They are very important. Know how lithium neuroleptic malignant syndrome differs from serotonin syndrome. Fever, both will have. Autonomic instability, both will have. Generalized rigidity, more likely to be neuroleptic malignant syndrome. Myoclonic jerks, more likely to be serotonin syndrome, right? Treatment with antipsychotic, more likely neuroleptic. Antidepressant, serotonin syndrome. So there are various things, right? CPK level will be high in serotonin syndrome also with the muscle twitching, but not as high as neuroleptic malignant syndrome. So you need to know these things to make a clinical diagnosis. Management of a suicidal patient, I'm sure you all have done separately. If you all haven't done it, mention. We can do that as well. Remember this, and you have to inform your seniors and manage. Okay, right. So know these conditions well. Right, you all answered also well. So that means you all are studying. So well done. Do you all have any questions? So one person with arm raised was an accident. Okay. That's a good question. If the patient who became aggressive towards attendant had presented with evidence of head injury, how can we proceed? So that's a difficult one. That's why you say there's no head injury. But if there is a head injury, what you're worried about is something like an extradural hemorrhage or a chronic subdural hemorrhage. Still, if they are hitting people and they are at a risk to themselves, you manage the same way, right? But you're more worried about their conscious level, right? Because that head injury in itself can reduce the GCS. So you don't want to sedate them too much, because if you sedate, you don't know if their GCS is going down. So on MRI scans, if it's a large SOL or something, and they are being very aggressive and they have no past psychotic features, you would do a completely neurological management and they would have to go in quickly. So it is liaison with the neurologist, neurosurgeon if they are there, but you will still sedate, but they will come and look at the MRI scans, do a neurological examination and say, there is a large bleed. This man is being aggressive because of this frontal hemorrhage. We need to drain it or something, and they will take over. But for the risk, you have to treat. You won't be given that complex situations, right? Don't worry. Yeah. Actually, what are the drugs that can be given as HO without getting senior opinion? I'm not going to comment on medicine and all, but I would assume that you can give anything. If a patient's blood pressure is 200 and 140, you should give something quickly. But from psychiatric point of view, you can always give the fast-acting things like haloperidol, olanzapine, if they're agitated, can be given. You don't need to diagnose depression and give antidepressants. Antidepressants take 2 weeks to act, no? You don't need to start on lithium. Lithium takes a long time to act. So a lot of the things take a long time to act. But if they are agitated, I think the only thing from a psychiatric point of view is giving haloperidol oral, olanzapine oral, clonazepam oral within the small doses are perfectly fine. If a patient has been on medication before, you have a prescription, they have tolerated it well, you can restart it without waiting for seniors. But something like IM haloperidol, which can later on give NMS, if the consultant tells and it gets to NMS, consultant will say, 0.2% of people get it here. If you go and give IM haloperidol without telling anybody, and the patient gets NMS, they'll be like, I may make a dunne killer. So always inform and give invasive ones. But from a psychiatric point of view, oral antipsychotics, which act quickly, and oral benzodiazepines, which act quickly to calm a patient, are okay. But the others, there's no point giving it yourself because they take a long time to act. So you might as well wait for the registrar, SRO, depending on your station, the consultant comes. Yeah. Okay then. Right. Good night. Thank you.
Thank you, sir.
Yes.